Okay, we're going to go ahead and get started. Now, last time we left off talking about different ways that we can measure different volumes and capacities to give us indications of potential disease problems or the progression of a particular disease. We mentioned how we can look at total lung capacities, FRC, residual volume, vital capacity, and make sure you have a good understanding of what these terms are. And you can see how these can change with disease. In this example, we have emphysema. Once again, you can see that we have an increase in residual volume, increase in functional residual capacity, and actually a decrease in vital capacity. Very important when we're talking about emphysema. And we also mentioned how we can measure a forced expiration. So forced expiratory volume in 1 second. This gives us an indication of airway resistance. So that value is also very important, and therefore looking at the fraction of forced expiratory volume in 1 second versus forced vital capacity, that gives us a percent. Remember, a normal percent is about 75%. In this case, in emphysema, is decreased to 33%. So make sure you understand these relationships, primarily to the different volumes and capacities. So this is another way in which they can chart some of these volumes and forced expiratory volumes that we've talked about. In this case, when we look at this over a time frame and the volume, and remember this is an expiratory curve, so if we're looking at expiration, and if this is a forced expiration, you start at a total lung capacity, a maximal inhalation, so you inhale as much as you can, and then you're told to exhale as fast as possible and as deep as possible. In other words, exhale everything that you can possibly exhale. And that will push you all the way to a residual volume when you get to maximal exhalation. And this here is our forced vital capacity. This is our volume. And when we're looking at FEV1, here again, once again, this is 1 second. So we're looking at the volume that's expired in 1 second. In that case, we're looking at 3 liters. Okay? Make sure you know how to read these curves. Quite often, I will put a curve of some type on the exam, whether it's a curve like one of these, or when we talk about saturations, typically I will put one of those curves on. So make sure you can look at this curve and pull numbers off and be able to do basic calculations. I'm not going to ask anything too difficult as far as calculations on these. It won't be any more difficult than calculating your volumes or lung capacities like I demonstrated before. So another point that we look at here is a forced expiratory flow. Forced expiratory flow is something also that's going to give us an indication of airway resistance. So one way to calculate that is called FVF 25 to 75. That means we're looking at the forced expiratory flow, or the flow of air out of your lungs, between 25% and 75% of your vital capacity. So this can be calculated by looking at what your total forced vital capacity is, and then you can easily calculate what's 25% and what's 75%. So then you come over to this axis, you pick the volumes that are equal to 25% and the volume that's equal to 75%, and you draw a line between those 2 points. The slope of that line is your forced expiratory flow between those points. Okay, so this forced expiratory flow, this can also be called the mid-maximal expiratory flow, is a good indicator, and they'll use that clinically to diagnose different diseases associated with increased airway resistance. So make sure you can look at this graph, this chart, and just be able to pick off these numbers, know what they mean. Another loop that we can collect is diagnostic. This is a flow volume loop. This is the expiratory loop. So this would be during a expiration, and once again we're looking at percent of vital capacity, peak expiratory flow rates. That's going to be a very important one. That's something that we don't get from this table, but when we do a flow loop, we can actually get a peak expiratory flow rate. If you think about it, if you're sitting in your chair and you do a forced exhalation, the air coming out is coming out at a particular rate. Now, as you initiate a forced expiration, the flow increases as you build up capacity, as you contract the expiratory muscles to a maximum. Now, once you reach this maximal peak, you continue your expiration all the way to your residual volume. So you're doing a forced expiration all the way to the maximal expiration. But you can see the flow rate decreases. That's because the capacity to push air out decreases when your muscles are contracted. So the further they are contracted and the smaller the volume in your lungs allows you to push less forcefully. Okay, you can take a full lung capacity and put a lot more force on it than you can a small lung capacity. It's kind of like a balloon. You blow it up a little bit, push the air out of it quickly. Well, you can't get a lot of force on a balloon that's only got a little air in it to start with. But if you take one that's got a lot of volume in it and push the air out, you've got a lot more force to it and you're going to get a much higher flow rate. That's the same thing here when we're talking about expiration. So this is your peak expiratory flow rate. Once again, that gives you an indication of where or how much airway resistance you may have. And we're not going to be concerned. Now, this is forced expiratory flow, typically of 25% of vital capacity. They also have an FEF 50, which can be calculated, and FEF 75. The shape of this curve does indicate some aspects of disease. We're not going to go into a lot of variations on that. We're not going to be concerned with these numbers as much. But make sure you can understand it here when we talk about the FEF 25-75, and also make sure you understand what peak expiratory flow rate means, especially where that comes into play with regard to your expiratory flow. And once again, you can look at the inspiratory limb on this as well, as you start from a maximal expiration, residual volume, and inspire. So now you take in a deep inspiration, and this is going to give you flow rate. These numbers are negative because the flow is going in the opposite direction. Flows outward here, inward here. Therefore, we get the negative. But the volume loop, you can see, follows a different pattern typically than what you see in your expiratory loop. So inspiration and expiratory loops are different, and we're going to see that a little later on when we see full circle loops. But remember, we talked about inspiration. Different things that can affect this inspiratory loop are inspiratory muscles, recoil of the lung. We talked about diseases that affect recoil of the lung, like emphysema, airway resistance. Any type of chronic obstructive pulmonary disease will affect airway resistance. Therefore, this loop will change its shape and numbers relative to disease as well. But make sure you can understand just what the primary loop looks like, and that you can look at this and know that 4 liters, that is the maximum forced vital capacity. This number here represents, is that your point of residual volume? If you're looking at total residual volume, which we can't measure, that's an additional volume here that's in your lung. So this is your vital capacity, and this here would be a residual volume, but it's undefined because we do not know where it ends. Remember, residual volume is something we can measure only if we do total lung capacities, probably doing a helium dilution type study. All right, so make sure you can understand these different loops, just what the points are, that if I ask you a question concerning these different aspects, that you can pull that off of this and know what it means. Now we're going to talk more specifically about respiratory system mechanics. Okay, respiratory system mechanics. So we're going to be talking about the lung itself as far as its ability to expand and recoil, chest wall, its ability to expand and recoil. And then is what we do is if we combine these two together, that gives us a respiratory system. Respiratory system is the lung and the chest wall combined. So that's ultimately what affects your respiratory mechanics. Once again, we talked about that pleural space that surrounds the lung, how important that is to help pull the lung open as we increase the volume of the chest wall by contracting our inspiratory muscles. And this here's a better example. Here, if we take a normal lung at rest, we have our pleural space, that's that little fluid space in between the chest wall and the lung, as you can see here. And so we have our ribs, which represents the chest wall, the lungs. So normal lung at rest, when it means normal lung at rest, that means we're at end expiration, a typical normal end expiration. At this point, the lungs still want to recoil and collapse. Okay, so they want to recoil. And at end expiration, the rib cage itself wants to expand. Okay, due to the elasticity of the rib cage. In other words, the muscles and the ribs combined create this elastic structure. So when we exhale, we can squeeze it in, and when we inhale, we can pull it out. So at the point of end expiration, in other words, our lungs have a FRC, a functional residual capacity. That's the volume that's left in the lungs at end expiration. So at this point, the rib cage wants to expand outward, the lungs want to collapse inward. So what's that create in this pleural space? It creates a negative pressure. Okay? In this case, we're looking at a -3 millimeters of mercury, so it's a very small pressure, but nonetheless it is negative. And that's in this intrapleural space. And that is compared to barometric pressure or air pressure. So it's 3 millimeters of mercury lower than the surrounding air. Okay, so it's very important that you understand this, and we're going to look at some various curves looking at the chest wall and the lung in relationship during an entire breath. So this is just a starting point. An example we want to point out here, now if we take this pleural space, which is typically at a -3, and if we puncture this in such a way that we allow that negative pressure to become equal to atmosphere, this is what happens. The lung, because it wants to recoil, will collapse. So the lung continues to recoil all the way down to a very small volume, because that's the elastic recoil of the lung. Remember, we talked about how important it is to maintain the lung open because of we talked about hydrostatic pressure of the water. If you bring it all the way closed, it's very difficult to open. So if we maintain it to a partial degree of openness, it inflates much easier, much less work of breathing. Okay, so it's very important. So here, if we puncture this pleural space, atmosphere pressure becomes equal to pleural pressure, lung collapses. It's not shown here very well, but this rib cage actually expands outward. Now, this is called a pneumothorax. Okay? So clinically, if you have a pneumothorax, that means your pleural space is compromised and it's equilibrated with barometric pressure. Okay? And at that point, the elastic recoil of the chest moves outward and the elastic recoil of the lung pulls inward. So clinically, if you were to see a person, they come into the ER complaining of chest pain, if you look at their chest, and remember we said the right and the left chest have separate pleural cavities, okay? They're divided. So if you have a puncture wound on one side, first indicator is going to be that the rib cage on one side of the chest is expanded. Okay, it's going to be bulging outward more so than the other side. And that's because of the recoil. And that lung on that side will be collapsed. And they will not be getting any air exchange. Because once this lung collapses, when you take a normal inspiration, it's going to go to the least resistance lung first. So because this is collapsed, it has a high opening pressure because of the hydrostatic pressure of it being collapsed. So only the other lung is going to ventilate normally. The collapsed lung will be very difficult to try and inflate. Now, a pneumothorax can also occur if we have a rupture from the inside of the lung to the pleural space. This can happen due to, once again, traumatic injury, where you have internal injury and causes a rupture, or it can be caused by various diseases, tumor, anything that may erode through this outer membrane here, outer pleura, the outer side of the lung, and cause an air leak into this space. That also will cause the same thing, a pneumothorax. This time there's no hole this way to atmosphere, but there's a hole going this way. And remember, your airway, as you breathe, is connected to atmospheric pressure. So at end expiration, when you come to atmospheric pressure, therefore, that pressure will equilibrate with the pleural space, your lung will collapse if there's a hole here. So you can have a pneumothorax either way, from external or from internal. So to continue with the pulmonary mechanics, we talk about the alveolar pressure. Now that's the pressure inside of the lung. We talk about the intrapleural pressure. That's the pressure in this pleural space, as we mentioned. And we can compare this to the volume or a tidal volume as we breathe. So as you look at this, and here we do, this is at FRC, end expiration. As you inhale a volume, remember this is inspiration, pleural pressure becomes more negative. So we start at about a -3, we go to about a -6. Now as we inspire, we increase the volume of the chest, we expand the chest wall, that creates more negative pressure on the lung, therefore creating this more negative pleural pressure. But as you can see, what happens to alveolar pressure? Alveolar pressure is relative to atmospheric pressure. So when we start an inspiration, we're at 0, we're equilibrated with the atmosphere. And as we inspire, we create a negative pressure in the airspace. That's what pulls air in. Now to represent all of this mechanics, I have this nifty little demonstration here. This jar represents your chest wall. In this case, it's a little more rigid than what we would usually have. And the balloon inside represents your lung. Remember, as your lung expands, it will recoil, just like a balloon. You let the air out, it'll recoil. Now, we will inflate these lungs, not by pushing air into them, but by creating a negative pressure in the pleural space. So by doing so, I just take this large syringe, I pull backwards. As I pull out, I create a negative pressure in the jar. So what that does is it pulls air into the lung. So we create a greater negative pressure, but that also creates a negative pressure inside the lung, and that's what pulls air in from the atmosphere. So remember, pressure moves, or gas flows from high pressure to low pressure. So we create a low pressure for the gas to move into the lungs. Now you can see that in here I have representative of 2 lungs. One is inflating and the other is not. What's that an example of? Now seeing that their pleural space is connected, we can't say it's a pneumothorax in this case. But it would be the same if there was a pneumothorax on one side was open. But in this case, this demonstrates the lack of surfactant. Remember we mentioned that surfactant lowers surface tension and makes it, and equilibrates or normalizes the opening or the air pressure. So you can see these balloons are slightly different size. They could represent alveoli of different sizes. And due to the different size, because there is no surfactant, the one that has the larger radius will inflate first. Now, if we had surfactant in here, or a soapy solution, as we talked about, as you blow bubbles, it decreases surface tension. And if we had surfactant and I pulled on this, it wouldn't matter if they were different sizes to start. They would normalize and they would both inflate at the same time. So that also represents alveoli in a surfactant deficient manner. We're going to talk more about surfactant in lectures to come. So don't be so concerned with that, but just make sure you understand that that's an example. So once again, you can see that it's a negative pleural pressure that inflates the lung. That's the idea of pulmonary mechanics. And most people don't think about that as you inhale, you think about, well, as you inhale, you're pushing air into your lungs. But you're really not. You're pulling air into your lungs with this negative pressure. So that's how important this negative pleural pressure is. Make sure you understand the relationship during a normal respiratory cycle. Inspiration, and once again, if you look at this pressure, once we get to a certain point of our inspiration and our airflow decreases or our lung volume increases, the pressure starts to come back to zero, because when you get to end inspiration, airflow stops. Airflow stops because now pressures are equal with atmospheric pressure. So make sure you understand, as you equal those pressures, airflow stops. Airflow only occurs when there's a difference in pressure. So as we achieve our maximum negative pleural pressure, we stop the airflow. So we inhale, we contract inhalation muscles, and then we reach our maximum, stops, airflow stops, pressure normalizes, we reach our maximum volume, and then we exhale. So once again, we exhale, everything goes in the opposite direction. Pleural pressure becomes less negative, but it's always negative. And alveolar pressure, once again, now becomes positive, because that's a direction of airflow. That's what pushes the air out of the lungs. And that's the recoil of the lung and the recoil of the rib cage. And we're going to talk about the relationship because they're not directly in sync. We'll see that in a little bit. So all this does here, the next 3 slides, just repeats what we've just talked about, that we talk about on inspiration. This is our pleural pressure here. This is our alveolar pressure. This is our elastic pressure. Elastic pressure is nothing more than the recoil of the lung. And this is our lung pressure, or our total lung pressure, which is the difference between the alveolar space and the pleural space. We'll talk about that definition in a minute. So this is nothing more than, as we inspire, we change these pressures. Oops, I guess I skipped the other 2. But so if we look at the equations here, transpulmonary pressure is the trans-lung pressure. That's the pressure that we just referred to as the alveolar pressure minus the pleural pressure. So that's the difference between the alveolar pressure and the pleural pressure. That's what gives us our total lung pressure. So that takes into consideration our elastic recoil. So if we look at alveolar pressure, that's defined as the elastic pressure, or the recoil of the lung, plus the pleural pressure. Pleural pressure regulates how much recoil we're allowing. So those are in opposition or in combination, depending if we're inhaling or exhaling. And the lung pressure itself is therefore equal to the elastic pressure. But as what I want you to do is just understand that the total lung pressure is the difference between the alveolar pressure and the pleural pressure. So once again, we look at this interaction, chest wall, lung interaction. The elastic recoil of the lung is inward. Recoil of the chest wall is outward. Our pleural space, diaphragm, And remember, at FRC, functional residual capacity, that's at an end of a normal expiration. So under those conditions, this is approximately where we sit. Here it says -5. In the other demonstration we had -3. So it's in that range. It does vary a little bit depending on person to person for one thing, and also atmospheric pressure, etc. So there are a variety of different modifications, but approximately is -3 to -5 in pleural pressure at end expiration. And at this point, these are vectors. You know what a vector is, right? Mathematically, it means if the vector is the same length going in both directions, they are equal. That represents force. Okay, so now you can see that the elastic recoil of the lung is equal to the elastic recoil of the chest wall, or our lung and our chest wall are equal in pressure due to the pleural space. The negative pressure here is pulling them together as they want to pull apart. So, sequence of events. First of all, we have a reason for inspiration. In other words, it's regulated by our CO2 levels, our oxygen levels. We're going to talk about regulation of inspiration later on. But a signal comes from our brain that says inspiratory muscles contract. So as the inspiratory muscles contract, chest wall expands. Pleural pressure becomes more subatmospheric. Lungs expand. Alveolar pressure becomes subatmospheric. Air flows into the alveoli. Okay, so it's a sequence of events, but it starts with the inspiratory muscles, which start to initiate the more negative pleural pressure. Once again, this is just what we talked about when we're talking about the pressures, the rib cage, and collapse. So make sure you understand that pneumothorax can come from the outside or from the inside, and make sure you understand these forces. Now that we talked about them a little more, it makes a little more sense that the ribs are going to expand, the lungs are going to collapse if we lose this negative pleural pressure in the pleural space. Now, this chart here, I want you to be able to recreate this at any time so that you can understand the relationship between the pressures of the lung. So here we're looking at the lung. This dotted line represents the lung. Now remember, we said that the pleural pressure is always negative. Here they show it in a reverse order, but the pleural pressure is negative. This is the pressure of the lung. The lung always wants to recoil. So as the lung always wants to recoil, the force is always in the same direction. That's why it's always positive, because we have a recoil of the lung. Okay, so as we increase the volume, in this case this is percent of vital capacity. So as we take an inspiration, a maximal inspiration, as we inspire, now this line down here, it goes to 0, but this is percent vital capacity. So at 0% vital capacity, we're at residual volume. So there is still a volume under here, but remember this axis is just looking at percent of vital capacity. So at residual volume, as we increase the volume of the lung, the more volume we put in the lung, the more the force of the lung wants to recoil. So the pressure of the lung increases as we increase the volume. That's your important take-home message right there. It's always positive because the lung is always expanded even at residual volume. Remember, we said that residual volume keeps them slightly expanded. So that's why there's always a force here. The lung always wants to collapse. So even at the end of a forced exhalation where we have only a residual volume, the lung still wants to recoil and collapse. Previously we were talking about FRC, which was end of a normal expiration. This here is FRC at this point. So at FRC, you can see that the lung has even more pressure on it and wants to collapse. So this is the difference between residual volume and functional residual capacity. This is maximal forced exhalation. This is normal exhalation. Okay, that's the volume difference, but that's the difference of the force on the recoil of the lung. Now, if we look at the chest wall in relation to this, remember, during normal ventilation, the chest wall wants to go in the opposite direction. The lung wants to collapse, the chest wall wants to expand. So even at a residual volume, you can see this is our maximal force on the chest wall. And if you think about it, if you do a forced exhalation, you're pushing that chest wall in to do that. Okay? You're using the internal intercostals, you're using the stomach muscles, the abdominal muscles, and you're forcing all that air out. But you're pushing that rib cage in. That rib cage wants to spring back out. Okay? So every time you exhale, you're forcing that rib cage in. You're creating more force, more recoil force as you push it in. So that's why the force here is a negative number, but you can see it's about a negative 35 relative to a positive 5 of the lung. So at this point, they are maximally different and want to move in different directions. This wants to recoil, this wants to expand. Okay, so there's huge difference between them. But at an FRC, what do you see here? Once again, if you figure this as a vector, the distance from here to here and from 0 to the lung or rib cage, they're equal. So at FRC, those two forces are equal and opposite. That's why when you relax your respirations, the forces go to an equilibrium. So the force of recoil of the lung and the force of recoil of the chest wall equalize. Therefore, that's FRC. That's normal exhalation. That's why you can passively exhale, and this is where your exhalation stops. It doesn't continue down further to a lower volume because of these equal forces. Remember, pressure is 0 at this point. This solid line is a combination or a summation of these two forces. So here, it's 0. So both forces are equal, no air movement, no force in either direction. No muscle contraction, no tension, everything is at 0. So as we inhale further, once again, we increase the elastic recoil of the lung, but as we inhale, we decrease the elastic recoil of the chest wall. At this point here, this is where the chest wall is at a neutral point, where the chest wall now says, I'm at 0 pressure, but we're talking only of the chest wall. So the chest wall doesn't want to move in or out at this point. This point is above and beyond a normal tidal volume. A normal tidal volume ends about here. Okay? So as you sit there breathing, your chest wall never reaches this point under normal respiratory conditions. So the chest wall always wants to recoil out. The lung always wants to collapse in under all normal breathing. Now, if you're exercising, doing increased ventilation, tidal volume rate, now you're going to be doing additional forced inhalation. So now you're going to use extra effort to inhale. So as you increase to a higher volume, now the chest wall crosses this line. And now you can see that the chest wall and the lung both want to recoil inward. So as you expand your lungs above and beyond your normal tidal volume, now you have more force of the lung and the chest wall wanting to exhale. But they recoil in the same direction. So as you relax, the chest wall is going to move back toward this direction, and the lung is going to recoil. So ultimately, when you get to this point, it's the lung recoil that takes over until these forces become equal. Okay? Make sure you understand where these different points are. So if I ask you on a chart like this, if I just put a single line on there and say that's the chest force of the chest wall, at what volume or vital capacity is a chest wall at a neutral position? Make sure you can understand that's where it crosses the zero line. As well, FRC, that's a combination of the two forces. Okay, make sure you understand the relationship of these three lines. This here does nothing more than go over what we just talked about. We talk about here we have the force of the lung recoil, force of the chest wall. This is maximal force of the chest wall wanting to come open. As we get to FRC, these forces are equal. Once again, these are vectors. Now, on this axis, this is percent of total lung capacity, which is different than vital capacity. So here you can actually see the residual volume here. So this axis is a little different than the slide we just looked at, so don't get confused between those. So here we go, FRC, these are vectors, and then as we go above FRC, as we can see that the chest wall here goes in one direction, and as we exceed, see this is just a single line on here. So as we exceed the neutral point of the chest wall, now you can see both vectors going in the same direction. Okay, so make sure you understand where the chest wall now adds to the elastic recoil or the passive exhalation and where it doesn't. So as you can see, we're going to go ahead and have a couple questions here. We're going to try top hat monocle again. So go ahead and prepare for your questions. Oops. And here we go. Okay, this will be question 1. Everybody ready? No? You have 3 minutes, so you actually have plenty of time. Typically, I wouldn't give you any more than a minute to answer this, but we'll give you plenty of time. So there we go. Which muscle group is contracted during active expiration? Like I said, you typically wouldn't need more than 10 seconds to answer this. I hope you, by now, you should be able to answer this rather quickly. And we will have one more question after this. Now, as soon as we reach 100%, we can stop and not have to wait the 3 minutes. So go ahead and make sure you get your answer. Now, in the future, some of these questions, I will limit them to a much shorter time period. So, first time through, plenty of time. Make sure I understand how this is all working. I know you guys have done this before. All right, we still have 5 people who haven't answered. Okay. The answer is internal intercostals. And why did it start again? I don't know. Disable submission. Okay. All right, I'm sure everybody got that correct, did they not? Where is it? That one? No. Reports. There it is. See, I told you, you guys know this better than I do. Okay, 91% of you got it right. The other 9%, you need to listen a little more in class. Those are the basics. Very simple. Okay. So next we're going to go to the next question, which I'm sure I can get there somehow from here, right? Probably not. See, I tell you, the worst thing is we can't do this in our office. We can only do that here in the classroom. It's the only place that this program exists, so I didn't get a chance to play with that. Okay, how do I get back to my next one? Try that? Items. You're right. That would probably do it. There we go. Okay, we're going to go to question 2. Which respiratory disease is associated with loss of elastic fibers, resulting in increased compliance? Once again, this should not take you very long. I know you're all logged in, so we should get 100% this time, much quicker. Now, while you're looking at this, review the 4 different diseases in front of you. Think about the different aspects that we talked about for each of these. And I'll even give you a clue. RDS stands for respiratory distress syndrome. Make sure you understand these abbreviations also. I will not always give those to you on the exam. All right, we have 100%. No? Does that mean somebody's not even logged on yet? Because it says we have 100% of those logged on. Come on. We're wasting valuable teaching time here. I can tell you're all very anxious to learn more. Yeah. All right, is everybody in? If not, yell. Raise your hand. Now, come on here. You're holding up progress. You're okay now? All right. Emphysema. Remember, we increase compliance because we deteriorate the elastic fibers, therefore we have no elastic recoil. Okay? Loss of elastic fibers. That is the only disease that actually has a loss of elastic fibers when we talk about all the diseases that we refer to. Okay, well, thank you for participating in that. That was much fun. We will continue on. Now we're going to talk about surface tension. Remember, surface tension, what was the primary compound we're going to refer to? Surfactant. Of those diseases that were listed on that last question, which one is relevant to surfactant and surface tension? RDS. Okay? Very good. This here is what kind of epithelial cell? Type 2. Very good. See, somebody's listening. I just had to check. All right, this is type 2 epithelial cell where we secrete surfactant into the air spaces. Remember, type 1 and type 2 epithelial cells are only found in the respiratory zone, the part where gas exchange occurs. In the conducting air zone, we have ciliated epithelial cells. So in the entire respiratory tract, there's primary 3 epithelial cells. There's the ciliated epithelial cells, the type 1 epithelial cells. Remember, type 1 epithelial cells are equal number to the type 2 epithelial cells, but they cover up to 98% of the alveolar surface. Therefore, these type 2 cells are very small relative to the type 1 cells as far as surface area. They're taller, they're columnar, but their primary function is to secrete surfactant. This here, surfactant is secreted in what's called lamellar bodies. So these lamellar bodies are secreted from type 2 cells. And as I mentioned before, type 2 cells are typically found in the corners of alveoli. So this here is a corner of the alveoli, and here's a type 2 cell. And this would be a type 1 cell. You can see here, this is an endothelial cell. So here we can see that there's a very short distance between the vasculature and the airspace when we're talking about type 1 cells. But gas exchange does not come through the type 2 cells very well because look at the thickness and distance that gas would have to travel. So type 2 cells are not very good for gas exchange. As you can see, they don't even really associate. This is vasculature here. This is vasculature over here. There's not even really vasculature associated with the type 2 cells for gas exchange. So very important to remember that. So as we look at this, we talked about surfactant being secreted from the type 2 cells. That's to decrease surface tension. All of this also helps to facilitate the exchange of oxygen and CO2, which we're going to talk about. The decrease in surface tension allows the alveoli to expand. And when they expand, they allow fresh gas to come in, which has more oxygen and less CO2 in it. So now we facilitate diffusion to the pulmonary vasculature. And once again, this distance is very critical to gas exchange. Compliance and elastance. Surfactant is essential for compliance, affects compliance dramatically. Compliance is nothing more than change in volume per change in pressure. So as we inhale, we change the pressure and we change the volume. That gives us a compliance of the surface. So if we looked at the compliance of this smaller balloon versus this bigger balloon, obviously the compliance of the bigger balloon is better. That's why it will inflate. And in this case, they're surfactant deficient. The balloons are, that is. So we're going to talk about how the compliance is the ability of the lung to stretch, but primarily it affects the work of breathing as well. Very important, especially when we talk about somebody with emphysema. We talked about a work of breathing. Remember, if you have emphysema, you have to force all of your exhalations. You can't passively exhale. Therefore, you burn up a lot more energy. The work of breathing is increased dramatically if we have emphysema. Now we're going to talk about restrictive lung disease. That reduces compliance of the lung. And in this category of restrictive lung disease, we have two primary diseases we're going to talk about. One is fibrotic lung disease. Fibrotic lung disease is where we have inelastic scar tissue in the lung. Fibrotic lung disease can be caused from a variety of different exposures. It can be an exposure to extreme heat, which causes lung injury. And as that injury heals, it heals with scar tissue, and we lose some of the elasticity. If anybody has a scar on your body, and if you look at that scar and you try to stretch it, you can stretch the skin next to it, and that stretches more easily than scar tissue does. Scar tissue is inelastic. It does not stretch. Scar tissue has more collagen in it than it does elastin. Elastin stretches. Collagen does not stretch as much. So as what happens is in fibrotic lung disease, we have injury. This can be due to infection, bacterial infection, viral infections. Anything that causes an inflammatory response can create lung tissue or fibrotic lung disease. Therefore, it will not stretch as well. So it prevents the elasticity from stretching this inelastic scar tissue. The other is respiratory distress syndrome, lack of surfactant in the lung. This occurs and when you have lack of surfactant, you have a decrease in compliance. Compliance of the lungs is decreased because surfactant decreases surface tension, which allows it to expand more easily. We talked about that when you're blowing a balloon. You add soap to it, that's like surfactant. Decreases surface tension, it expands easily. If you don't, you just have water. That water does not have very good expansion to it. It'll burst because it doesn't expand. So once again, that's what respiratory distress syndrome is. It usually occurs in premature babies because it's part of lung development. Type 2 cells do not secrete surfactant until approximately 31 weeks of gestation. Okay? So if you have a premature baby that's less than 31 weeks, it will be surfactant deficient. Nowadays, they have other sources of surfactant that they can produce and that they can give premature babies, and they do this routinely. If a baby's premature, they give it a dose of surfactant into its airway before it takes its first breath. The importance of giving it before that first breath is so you get a better distribution. Surfactant primarily is in a liquid phase. So they put the surfactant in a liquid, and if your lungs are liquid filled, remember your lungs are purely liquid filled before you take that first breath. So now you put a liquid in a liquid, you get very nice dispersion of the surfactant. Liquid into liquid goes very well. And now as that baby takes that first breath, it inhales, all that surfactant is pulled out to the extremity, out to the distal portions, and coats the surface. Therefore, giving it good compliance and allowing that lung to expand. Without that, a premature baby has very poor expansion of the alveoli. They get small volumes of gas into their lungs, therefore poor gas exchange. So it's very important to get that surfactant in there as early as possible. One of the other reasons is if you don't give surfactant and they don't have good lung expansion, typically they'll use mechanical ventilation to push that extra volume into their lungs so they get good gas exchange. If you take a very non-compliant lung and you force air into it, you cause injury. It's called barotrauma. So the forced air into a non-compliant lung causes stretch on it where it typically would not stretch and can cause injury. As a result, you can end up with a fibrotic lung disease, a form of fibrotic lung disease. So it's important to give surfactant to premature babies. Now, if we talk about compliance, once again, we talked about how RDS and fibrosis decrease compliance. You can see by this curve, this blue line, this is a normal compliance curve. So with fibrosis or RDS, we decrease compliance. In other words, it takes more pressure to try to get volume into the lungs. Now, on the other hand, we talked about emphysema already. With emphysema, we have a deterioration of the elastic fibers within the lung. Therefore, we lose that elasticity and we increase compliance. Those lungs will expand extremely easy. However, they will not recoil and give us proper exhalation. So here, if you look at compliance, you can see that we have an increase in compliance when we're referring to emphysema. Elastance is the ability of the lung to recoil back to resting volume. Now, in this sense, when we talked about RDS and fibrosis, we don't necessarily affect elastance in these diseases. In these diseases, whatever expansion we get to that lung or the alveoli, it will recoil normally. However, in emphysema, we lose that recoil, so therefore we have a change of elastance, a decrease elastance. In other words, a decrease of recoil. So we can also talk about specific compliance, and that corrects for a decreased compliance at higher volumes. We're not going to be concerned with that, but what I do want you to understand is that compliance is decreased as volumes increase. So as you take a maximal inspiratory breath, and this only makes sense, it's the same as a balloon. If you blow a balloon up to what its normal volume is supposed to be, and now you overexpand that balloon, it takes more force to expand that balloon beyond its normal stretch. So you take any balloon or anything, or even a basketball, if you're inflating it, they're designed to expand to a certain point. If you go beyond that, you have very stiff compliance. So the higher you go beyond that normal expansion, it's very difficult. Same as a rubber band. You can stretch it to a certain point, but now if you want to stretch it way beyond, it takes more force to do so. So in other words, you lose compliance at much higher volumes. And that's the same with the lung. Now the lung has various mechanisms to restrict you from overexpanding it. One is the rib cage for one thing. As well, there are various receptors, baroreceptors within your lungs and your rib cage that tell your body to stop inhaling. So once it gets to a certain point, it says stop because you're reaching a danger point. So your body actually has those built-in mechanisms. Now the reason that surfactant decreases surface tension is because of the law of Laplace. Law of Laplace basically states that the pressure within a sphere is equal to the surface tension divided by the radius of the sphere. I'm not going to ask you to know that. What I do want you to know is what happens when we apply surfactant to the law of Laplace. So under normal conditions, the law of Laplace says that a larger bubble will take less pressure to inflate it than a smaller bubble. A smaller bubble will take more pressure. Now you can use that equation and make sure you understand that because we're talking about the radius and the surface tension. So as you can see, I talked about before how the surface tension is very high when we have no surfactant. That's because the water molecules want to hold together, and therefore it's very relevant to the radius. So the inflation pressure is relevant to the radius. Therefore, the larger radius will inflate with lower pressure. However, if we add surfactant, surfactant reduces surface tension to equalize these. Now here you can see the surface tension is the same. They're both at 3. That's because it's nothing but water. Has nothing in there to decrease surface tension. However, now if we take all alveoli and create them equally, in other words, they have equal number of type 2 cells to type 1 cells. The proportion of type 2 cells is the same whether it's a large or a small alveoli. Now, if we take and we expand the alveoli to an FRC, or a residual volume, they have a certain dimension and volume to them. In doing so, we have a different radius. So we have radius of 2, radius of 1. And so remember also that we talked about the septae within the alveoli. They all vary a little bit. The sizes of the alveoli vary. Sometimes they can join together and make larger alveoli. So the radius can vary. Now the important thing here is that the surface tension with surfactant, first of all, is less than without. Here it's 3. Here it's 2 or 1. The reason that it's 2 or 1 is because of the quantity of surfactant that we have in here. So here you take equal number of type 2 cells in both alveoli. Because one is more expanded, we have a larger surface area, larger volume of surface water. Therefore, the surfactant is diluted. So this decreases surface tension only to 2 because we have a dilution effect as it expands. Here, a smaller alveoli, or one that's more collapsed, has a concentrated surfactant. Therefore, the concentration is higher, decreases surface tension to a greater extent. But as you can see, the pressure required to inflate both of these is equal. Therefore, in our lung, because we have inhomogeneous inflations and deflations at our FRC, kind of like these balloons at FRC, they have different inflations. However, with surfactant, these will inflate equally. So that's the concept I want you to understand, the purpose of lowering surface tension to give us equal inflation of the entire lung together. Now, surfactant is comprised primarily of phospholipids, 85 to 90%, being the primary phospholipids being phosphatidylcholine, dipalmitoyl, DPPC. It also has a lot of neutral lipids, fatty acids, and proteins. It contains 10 to 15% of very specific proteins. Surfactant protein A, B, C, and D. These proteins are very important, even though they're in small quantity. They regulate surfactant turnover. They help with the immune regulation within the lung. They help with the formation of tubular myelin and surface tension and spreading ability. So without these proteins, you do not get proper function of the surfactant that is secreted. So with the synthetic surfactants that they make for clinical use for preterm babies, it was very important for them to develop these and get the ratios proper of these various proteins associated with the various phospholipids. There's one surfactant company here in Buffalo that was on the forefront that developed one of the earliest surfactants. He was a neonatologist. I did a lot of work with them in developing the surfactant. They use it clinically throughout the world. It's very important, but a lot of that work and development was right here in Buffalo. So just one link to give you an understanding of some of the research that occurs here. So are there any questions concerning surfactant and surface tension? This here, once again, just talks about with surfactant, without surfactant. Remember, the surfactant helps prevent the alveoli from collapsing because it decreases surface tension. Remember that hydrostatic pressure wants to pull those water molecules together, but with surfactant, it disperses that tension and therefore you don't have that force of the water molecules wanting to pull together. And once again, secretion of surfactant is the type 2 epithelial cells. They exocytose the lamellar bodies, which is a surfactant. And exocytosis can be regulated by beta-adrenergic agonists, activators of the phosphatidyl kinase system, PKC, leukotrienes, purogenic agonists. So there's a variety of different things that can help to activate the secretion of surfactant. But one of the primary things that helps with surfactant secretion is now and then, if you know what, when you take a sigh, one of the purposes of taking a sigh is nothing more than a deep breath relaxation, a slow deep breath. That expansion or overexpansion of the lung helps to secrete surfactant. So it rejuvenates the surfactant within your lungs, and it's very important. So when you take a sigh, all you're doing is recoating the surface of the lungs, because if you sit still for a long period of time and you don't expand the lungs, you're breathing very shallow, the lungs have a tendency not to secrete as much surfactant as they typically would. So just inflation of the lung is a very good source of secreting surfactant. Clearance of surfactant can occur through the reuptake by the type 2 cells, also absorption into the lymphatics. Remember we said the lymphatics help control that fluid volume, and also clearance by alveolar macrophages. They will actually take up some of that surfactant as well. So you certainly need to keep replacing it, replenishing it. Lung compliance, as we already mentioned, is nothing more than a change of volume per change of pressure. Lung development and growth occur until young adulthood, until you're 20 to 25 years of age. So that's a very important point, because the alveoli are always developing. The relationship between the type 2 cells, which are progenitor cells for type 1 cells, very important in growth so that they can increase in numbers. Also, from this point, decreasing in lung function with age. As you reach 20 to 25 years of age, you lose about 1% of your lung function per year. So maintaining proper lung health is important, because as you age, you will already have a deterioration of your lung function. So anything that you do in addition to that, like smoking or exposure to other toxins, etc., can even increase the rate of degradation of that function. So once again, when we looked at pressure volume curves of the lung, this is what we've looked at. To look at this again, when we talked about deflation or a pressure volume curve, pressure volume curves are one of the things that we do to measure compliance. So when we're talking about surfactant deficiency, these compliance curves or lung deflation curves are what we typically use. So here we would look at in a deflation curve. So here we're looking at an exhalation curve. We compare the rate of inflation with volume and pressure. So we have pressure here, volume here. The slope of this curve gives us compliance. So if I were to give you a curve like this and say, okay, what is the compliance of this? You should know that it's the change in volume per change in pressure. So you should be able to look at this and measure that or calculate that. Now, a normal compliance is 0.2 liters per centimeter of water. Compliance decreases with increase in volume, as we mentioned. So if you look at this curve, just look at the slope. You can see the slope of this curve decreases. Therefore, compliance decreases. So if I were to give you two curves, you should be able to say which one had a higher compliance than the other. All right, so make sure you understand the relationship of pressure volume curves relative to compliance. Once again, we've already looked at this, looking at compliance, normal compliance versus fibrosis or RDS, as well as emphysema. And once again, this just helps to summarize what we're looking at. Compliance, remember normal volumes, normal values, there's 200 ml of air per centimeter of water. So 200 ml per centimeter of water. This is a pressure of under normal compliance. Fibrosis with low compliance, the compliance can drop to half of that. And with emphysema with high compliance, we can go to fourfold the low compliance, or twice the normal compliance. So that's very distensible. This just gives you a range of the actual numbers that we're referring to, and so when you do the compliance calculations on these, that you can see that there is quite a big difference. So once again, when we look at a lung, and we talked about the importance of surfactant or air inflation, water inflation, remember water is very non-compliant. So if we put water into the lung to inflate it, first thing we're going to do is dilute the surfactant. Okay? So the biggest problem we do is we dilute the surfactant, so we decrease our compliance. Or as what we do here, we increase the compliance because we don't have the air-liquid interface. But also, we have water inflation to compare the water inflation with air inflation. This is what our typical compliance curve is going to look like. Water is not a good thing to have in your lungs. First of all, it decreases the ability for gas exchange dramatically. But this just gives you a relationship between the air and the water. Once again, our normal compliance curves here. And now when we talk about work of breathing, this is the additional thing that we want to talk about. We talked about lung recoil, elastic fibers. Elastic fibers contribute about 1/3 of the lung recoil. With fibrosis, we can alter recoil, we can increase recoil, decrease compliance. With emphysema, we decrease recoil, increase compliance. And then also if we talk about surface tension, that contributes about 2/3 to the work of breathing. Okay, so this is relative to the work of breathing. So surface tension, if we have surfactant deficiency, you can see how that increases the work of breathing dramatically, even more than fibrosis would or loss of elastic recoil. So in respiratory distress syndrome, decrease of surfactant, we get an increase of surface tension, decrease of compliance, but we increase the work of breathing dramatically. Airflow resistance, now we're going to talk more specifically about airflow resistance in this formula. So we'll talk about that, how that has an effect primarily in asthma, emphysema, anything that has what we call chronic obstructive pulmonary diseases, in other words, narrowing of the conductive airway, that will have increased airflow resistance. And so we'll talk about that more specifically here in just a moment. So under normal breathing, and as well with moderate exercise, we use 1 to 3% of our oxygen consumption for breathing. We're going to get into oxygen consumption. Pulmonary diseases use 20 to 30% of our oxygen consumption. So you can see that we increase our oxygen consumption tenfold if we have a pulmonary disease. Once again, this relates to work of breathing. If we increase the work of breathing due to disease, our oxygen consumption increases. So what happens if we increase our oxygen consumption? Now we're going to increase our respiration. Well, increasing your respirations in an already diseased lung sometimes can even further the advancement of the disease. So it's even more difficult. And patterns of breathing, we're going to talk about here, that changes in various types of lung disease, because as we increase oxygen consumption, now we have to increase or alter our pattern of breathing. This here is minute ventilation. We're going to talk about that in more detail. That's equal to the tidal volume times the frequency in which we breathe. Okay, so we talked about if you have increased oxygen demands, you're going to increase either your tidal volume and or the frequency of breathing so that we can bring in more oxygen to use in consumption. And lung recoil is a primary influence of tidal volume, and also airflow resistance influences frequency. Because if we have a lot of resistance to airflow, we cannot increase our rate very much because we're pushing against a resistance. We'll talk about those in more detail as well. But once again, they all relate back to these pulmonary diseases and relative to compliance and work of breathing. So now we're going to talk more specifically about resistance, different factors that affect airway resistance. So if we talk about Poiseuille's law. Poiseuille's law says that resistance is equal to the length of the tube times the viscosity of the fluid or the air divided by the radius to the fourth power. So now we're going to talk about these different factors and how we can alter resistance under normal conditions or under disease conditions. The length of the system typically is constant and not a factor. Okay, in other words, the length of the system is your conducting airway. Okay, that's the length of the system. Physically, how can we alter the length of our system in addition to this? Can you think of any ways that we can change the length of our breathing system? Come on, think outside the box a little bit. All right, if you're breathing through a snorkel, what does that do to the length of your breathing tube? Increases it, right? Because now you're adding on the length of the snorkel. Everything has to come in. So what's that going to do to resistance? It's going to increase resistance. Okay? Now, if you have a tracheostomy, that's where they put a hole in your throat here due to some disease or other ailment or accident where your upper airway is damaged. They have to put a hole down here in your throat. What does that do to the length of your airway? Shortens it. So what does that do to airway resistance? Decreases. Okay? So even though we talk about it's fairly constant under normal conditions, there are ways that we can alter the length of the system. Viscosity of the air, once again, usually fairly constant. However, humidity and altitude can change the viscosity of the air. Humidity, we talk about it all the time. You know, if on a very hot, humid day, do you notice that it's more difficult to breathe? Okay? You say, wow, you know, your breathing's a little heavier. That's because of humidity. You've got water vapor in the air. You increase the viscosity of the air you're breathing. Therefore, you increase resistance. Okay? Increase resistance. Also, if we go to altitude, what happens to the viscosity of the air at altitude? Remember, at altitude, barometric pressure is much lower. Therefore, the gas molecules are farther apart. So therefore, we decrease the viscosity at altitude and we decrease resistance. Okay? There's a whole lot of other issues that occur at altitude, but one is we decrease resistance or the viscosity of the air. Diameters of the airways. How do we affect the diameters of the airways? The upper airway primarily, physical obstruction with mucus or other factors. So any mucus accumulation, a child inhales some small little styrofoam balls, anything that's physical that obstructs the upper airway. Also in the bronchioles, we get bronchial constriction. Remember, where there are no cartilage rings, there's a variety of things that can cause constriction as well as dilation. So we'll talk about more of these next time. Thank you.
question, Tom Monaco question about the muscle. Didn't you also talk about scaling was being part of passive expiration? Scaling muscle?
No, that's for active inspiration.
Active inspiration.
Yep. Abdominal muscles and the intercostal muscles are for expiration. Abdominal muscles primarily.
Thank you.
Yep.
Hi, Dr. Swartz. I had a question about the composition of the surfactant.
Yes.
I saw that the ranges of phospholipids, the percentage of a phospholipid in proteins is different, and they add up to 100 if you look at 10%, 50%.
Right.
So does the different amounts of percentages of those proteins, does that affect the influence of surfactant on the compliance?
Absolutely, and it also depends on which specific surfactants. So I mentioned there's 4 different A, B, C, and D. So it depends on which surfactant is there in higher quantities, relative ratios of different proteins, as well.